Professor Veena Ravi, who happens to be my class fellow, let me declare very clearly. We are batch fellows. Other distinguished speakers, you have already heard their names, and my dear colleagues from Lucknow. Lucknow is not new to me. I have been this, at least I can say that I have been for 41 years in KGM6, now KGMU itself. And then I had another 4 years before entering into the medical education into Lucknow. So almost I completed about 45 years. I left this city in 2011. And I think after coming this, I'm coming to this city as far as lectures are concerned, after 1 year, I believe, if I believe correctly. Thank you, Dr. Surkant and Dr. Kushwaha, for nice words. Today is another, I was just thinking, sitting there, I'm the luckiest one possibly, because all the vice chancellors of KGMU, starting from Professor K.M. Singh to Professor Ravi Kant, has listened one or another lecture. Also heard by my grandson, who is sitting probably in the back somewhere. Yes, he's there. And well, my talk is on tuberculosis. Jawaharlal Nehru and Dr. Rajendra Prasad, not me, that great guy, Dr. Rajendra Prasad, they have been associated in inauguration of this very great institute. Professor Ravi Kant, I have shown this KGMC, wherever I have gone. So the down reservoir, which was developed by CSIR and with the Cadila Pharma, when it was inaugurated by CSIR DG, and I was the guest of honor there. I happened to meet him. He was a wonderful personality, I must say. TB, whenever I teach, in the interest of time, I will skip many slides in between. This is 100% curable disease. I say I made this slide in 80 when I became lecturer from reading from the books. Because at that time I have 3-4 years of experience of my residency. But now I can say, after treating thousands and thousands of patients of tuberculosis, TB is really 100% curable disease, provided you prescribe adequately, not only prescribe, you make your patient to complete the therapy. But unfortunately, if you see the next slide, this figure is released just about few days back. What is the global scenario? 1.5 million means 15 lakh people. All sorts of happening. And then one question comes to our mind that why this is. And if I can take an hour lecture about why this is happening with all evidence base, but all the evidence base says that this poor treatment of TB patients. And why poor treatment of TB patients? To my understanding, whatever I have understood medicine till date, no doctor, मरीज मेरे पास आते हैं कहते हैं साहब डॉक्टर साहब ने क्यों ऐसी कुछ गड़बड़ी हो गई? हमने तो कोई डॉक्टर ऐसा नहीं होगा दुनिया में जो अपने मरीज को ठीक होते हुए देखना नहीं चाहता. So everybody wanted to write the right treatment. But what is the problem? Problem is around teaching. I have traveled the whole of the country, being president of all the organizations just, and I have seen there are hardly very separate departments, very few in Delhi. Professor Ravi Kant was in Delhi. Still, there are medical colleges where there is no department separately. And when anybody comes to, and how I can come, there is another way of knowing me. Pulmonary medicine, TB, chest, whatever you name. Hardly any student, because a student can only tell the name. But I'm very lucky, and I would like to inform Professor Ravi Kant, if somebody is from KGMC, he always tells the name of Department of Pulmonary Medicine. He always tells the name of who are the teachers, who are the heads, because there is a class. So what I'm trying to say, only poor treatment practices is because of poor teaching and training in medical institutions. I spent 3 minutes on how TB is diagnosed and what new things has come into the diagnosis of TB in last 10-15 years. You know, to diagnose TB, the first thing you have to suspect, not that it will jump from somewhere. For any disease, as a clinician, I always teach, first you have to suspect. I see in my OPD, gene expert, the report, usko TB nahi. So not only lab will tell that. The lab, there are limitations. I'll just deliberate. But so you have to suspect, and you know, all of you know how to suspect tuberculosis. No, but what is tuberculin test? What is Monte's test? New names, new methods is IGRA, quantiferon gold. Now quantiferon platinum has also come. They just tell one thing, that person is infected by Mycobacterium tuberculosis. Nothing else. It cannot. Radiology, no doubt, is a very sensitive test. Small lesion you may detect, but it is less specific test. It is very difficult to tell whether the shadow is tubercular or not, even at this stage of me, what to talk of other stages. So radiology is good, but the specificity is very low. Immunology, all of you, TB is diagnosed today. I would like to share one patient. He is 22-year young male having cough and breathlessness. So he was having background of asthma. But what new thing he developed? He developed hemoptysis. In India, hemoptysis is taken as synonymous for tuberculosis. Anyhow, this is a bad habit, but anyhow. And this was the X-ray. Somebody prescribed ATT. Don't know why. Maybe some lesion in the hilar area. After 6 months of 4-drug therapy, the second X-ray was the X-ray. All of you agree the lesion has progressed. And if you believe just on radiology, even if you show me these two X-ray pictures, I will say yes, disease has progressed. So this gentleman was diagnosed as MDR TB in somewhere near Sitapur. But doctor was very smart before he wrote the prescription for MDR TB in 2004. But he said, no, go to KGMC, confirm it before you take these medicines. So he came here, we did the first thing, sputum, which was negative. I said, this sputum parade is negative. When it is not TB, what is the question of MDR TB? This you have to understand very clearly. And finally, I will not go into any detail. Great hope, I will just deliberate it. And then bacteriology still is the gold standard. Still we say, get culture and sensitivity. And that is still even today it is a gold standard to diagnose. But what is the gold standard? You have to understand. Time will not permit me to go in detail, but if you read the third line, microbiology is not so easy what we understood. In vitro in vivo correlation is only reliable for INH, rifampicin, injectable and fluoroquine. None of the drugs. आजकल मरीज हम लोग पास आता पूछता है, कंपनी वाले पूछवाते हैं, लैब वाले कितने ड्रग्स से सेंसिटिविटी कर दिया जाए. Believe me, except these 4 drugs, all the sensitivity reports are not very reliable. So that you can understand, and I can share with you again hours and hours. This is a case of one of the lady which I treated, young lady. All the 4 lab differed in their reports, which is supposed to be the gold standard. Believe me, this is another lady when somebody was diagnosed with XDR-TB. What I am trying to say, on paper it says, but in this country, quality, other issues are there. So what is the gold standard may not be gold standard for every patient. So don't accept uncritically. We have many more methods to diagnose MDR-TB, especially the molecular biology, line probe and expert. Line probe was endorsed in 2008 by WHO. It can diagnose MDR-TB in 2 days. So it is all molecular biology. Gene expert has been endorsed again in 2010 by WHO, used frequently nowadays. It can diagnose TB first. It can also diagnose rifampicin resistance as a surrogate marker for MDR-TB. And this can be done within 2 hours. So this test, this molecular biological test, has really changed the game in the diagnosis of TB. Lot of things has to be done further also. If you see, even for extrapulmonary TB, there has been review in 2013 and 14 that for cerebrospinal fluid, for lymph node, for gastric lavage, it could be very good test, but for pleural fluid, its sensitivity is just 46%. Even Cochrane review has been done in this year for teen expert, and they say that it can diagnose TB, it can diagnose drug resistance. Keeping these things in possibility, so there has been a lot of change has occurred in diagnosis, so I am trying to convey. And then how to treat, maybe next 4 or 5 minutes, very crisp. When any patient comes to me even today, I used to classify the patient into 3 groups. One, whether he is a new patient. New is very simple. Either he has not taken any treatment or he has taken treatment of less than 4 weeks. He is a new case. Second, retreatment group, more than 4 weeks treatment. And then in the retreatment group, like MDR and XDR, drug resistant TB can be there. How to decide this regimen? For new TB cases, you have a very standard protocol, and this came out last guideline WHO 2009. People say 10 also because it came into the fag end of 2009. I have read it for 15, 16 times. And when I read it for 15, 16, I found there is an expiry date of this guideline, 4 to 5 years. So what I am trying to say, this is the possibly next year these guidelines is going to be revised. But still, till that day, what you said is start with the 4 drug, end up 2 drug or 3 drug. That usually we do while treating a case of new cases of tuberculosis. For retreatment group, those patients who has relapsed for the first time, who has failed even for the first time, those who have defaulted for the first time, chances of MDR and XDR TB is not very high in that group. That's why WHO has still made a recommendation that this is a CAT2 type of regimen where you start with 5 drugs for 2 months, 4 drugs for 1 month, and 3 drugs for 5 months, total duration being 8 to 9 months. So new case, 6 to 7 months. For retreatment group, where there is no MDR and XDR, 8 to 9 months of therapy. Well, MDR management, because now all of you, let me say before, how many of you treat tuberculosis? Raise your hand, please raise your hand. How many of you treat tuberculosis? So at least 25%, they have raised their hands. So apart from cardiologists, the crowd of physicians and other people also are talking. The guideline wise, as somebody was saying, the MDR guideline started from 97 when everything was great. I must salute my teacher, Professor Khanna here. When I meet him, even nowadays I meet him sometimes, he asked me one question, what curious the physician he has been. Rajen Naya kya aaya? TB mein? Is always says to make a regimen, proper regimen. Unfortunately, this is not being done in this country. How many new drugs, effective drugs you require? And this is answered by all the guidelines started from 2008 to 2014, at least 4 new drugs. And if you see, and how to decide these new drugs, there is now new classification. Again, it came in 2008 and 9. Probably it is going to be revised. Group 1, 2, 3, 4, 5. And these groupings are made on 2 bases. One is based on their experience of using them, and second based on efficacy. It tells very clearly, group 1 drug is the most efficacious, like primary drugs, ethambutol, pyrazimide and rifabutin, and group 5 drugs like clofazimine, linezolid, amoxicillin, they are the least efficacious drugs as far as TB management is concerned. So you try regimen for MDR TB of this country. Kanamycin, levofloxacin, ethionamide, cycloserine. So Government of India has added 4 new effective drugs. They have also added pyrazimide and ethambutol. Capromycin is injected, you see 6 to 12 months, and many more drugs. New are group 5 drugs have been added into the XDR-TB surgery. In some of the cases, you may think, what is future? Maybe next 5, 7, 8 minutes, I'll spend on the future. And you know, WHO gave slogan before 2015, but end the TB study. You know, other than that, what they say by 2035, there was 2050. Here in 2035, there will be 0 death, which you find today is 1.5 million. And there will be incidence would be reduced from 180 to near about below 20. So that is the target. To achieve that target, actually we require new diagnostic, better treatment, and better prevention. No doubt about it. You have heard there's a lot of new thing has happened in diagnostic. I have already shared with you. There's a new drug development. Last 40 years we have hardly any new drug. But now a lot of drugs are in pipeline. Let me tell to you, I will not go into any details, and time will not permit me to go into details, but at least drugs like Bedaquiline, like Dilamanin, 2 drugs. मैंने मोदी जी से सवाल किया था, सीनियर मोदी से, राजीव से, काली मिर्च खा लें तो क्या टीबी सही हो जाएगी? So I found from labs that probably you have to eat kali mirch in kilos and quintals. Then, so this is a pipeline is a very active ingredient from that. And what they have gram of rifampicin with 10 milligram of pipeline, active pipeline, then it becomes equivalent to 450. So with this, advantage could be